Thank you very much, and it's very nice of you all to come on a Sunday morning. So I've called this Practical PET because I'm not a PET-trained radiologist, but I do a lot of gynecologic imaging, and I reported PET for many years in my previous job, and I do a reasonable number of studies in PET in gynecologic cancer. So I will be talking a little bit about PET in research because that's predominantly what I do. But I would like to acknowledge some of my colleagues who helped me collect cases for this talk, Dr. Tara Barwick and Alice Munari. So just to talk about the technique, typically we'll be looking at eyes to thighs, as they say in the States. One point that I found very difficult when I was reporting PETs was that very often I found the PET radiographers were quite quick to decide that the patient's arms could be put down over the abdomen because very often it didn't matter too much for other types of PET. But for gynae cancers, I really advise the radiographers to keep the arms up if at all possible. And of course, some patients find this difficult in PET. But in the alternative, I say, okay, fine. If the patient's uncomfortable having the arms up, try and get the arms over the chest, not over the pelvis, because very often what we're trying to evaluate in gynecologic cancer is in the pelvic organs, such as, you know, if it's lymph node disease or what have you. So that's one of the issues in gynae which I found quite difficult. The other thing to just mention on the technique side is that don't forget that the low dose, there's probably some PET experts here, so I apologize, but the low dose attenuation correction CT is really not used for diagnostic purposes on the whole. It's just not high enough quality. And if you do want to have a CT scan, we will very often, for example, if a patient we know needs a PET, which I'll go into in a minute, and we know that they may need a diagnostic CT, we'll often then request a diagnostic CT with contrast after the PET. And we do the diagnostic CT always after the PET. We wouldn't want anything to go wrong with the timings, etc., for the uptake. So that's always done secondarily. What are the main indications for PET? Primary presentation is not really an indication for PET in gynecologic cancers. We don't really use it in this setting, but we do use it in staging in some situations. Response evaluation is something that I'll discuss. Restaging in potentially curable relapse is an important area in gynecologic cancer. And establishing disease sites and localizing disease sites as a cause of elevated tumor marker, for example, in elevated CA125, where no site of disease is seen on the CT, is quite an important indication. Imaging-guided biopsy is not really used, but in some settings, it may be that a PET-identified site of disease will be the chosen site for biopsy. We do use PET for radiotherapy planning in cervix cancer quite extensively. Now, it's very important for the PET radiologist to be able to have some background information, and this can really help improve the accuracy of their report. Obviously, they need to know clearly what the indication is. We need to know the height and weight of the patient, but that's obtained at the time the patient comes to the clinic. The tumor type and known sites is very helpful. If you're in the MDT and you suggest a PET, and you know that there's a potentially necrotic node or something like that might influence the PET, I think it's quite important to say to your clinicians, on the request card, can you please indicate that there's a necrotic node in the left pelvic sidewall, for example. I'll show you a case of that. It's important to know what prior oncology or inflammatory history is. For example, if a patient with a gynecologic cancer is also known to have sarcoidosis, it's very important for the PET radiologist to know this. Obviously, there's important technical information about diabetes and medication, results of other imaging, and renal function, etc. Good patient preparation is key. We want to reduce the tracer uptake in the normal tissues, such as the muscle, the myocardium, and the brown fat. And just, to remember that the patient should eat no sugar or food for 6 hours before the study, and they need to be well hydrated to reduce artifacts from the urine, and this is very important in the pelvis. And they have a quiet uptake period, they have to avoid exercise, and there's certain rules about diabetes which just have to be adhered to. When the patient is on chemotherapy, for example, if we're doing a response assessment study, they need to have the PET at least 10 days following the recent chemo dose. And don't forget that PET is a quantitative technique, and therefore there should be good QA procedures in place if you're using this as a response assessment measure, and as well for radiotherapy planning for tumor edge determination. This is an important factor. There's some additional factors in gynae. I mentioned the issue about the arms. But don't forget that physiological activity in the endometrium and ovaries in premenopausal women is present and can cause some consternation, but this is well recognized. But if there is incidental increased SUV in the endometrium or ovaries in the postmenopausal woman, in a patient having an FDG PET for another reason, then this does need to be further investigated as appropriate. Okay, so I'd like to go through our three main cancers, cervix, endometrium, and ovarian, and I'm going to look at how PET is used in the MDT setting in each of these tumor types. First, to say that in early-stage cervix cancer, there's no evidence to use PET-CT, and MRI is much better at delineating the tumor. There's a very small tumor here in the posterior aspect of the cervix. We can see this on the diffusion and on the ADC. And studies have shown that for T-staging, MRI is better than PET. And we just don't have enough spatial resolution on PET to look at the delineation of the tumor, the parametrial invasion. So it just doesn't perform so well. What about end staging? And of course, this is what everybody would love to use, and it is used in PET in a large number of advanced cases. If we just look at this, I've given you a lot of the literature here, and we can see quite a range of sensitivities from 100% down to 10%. And what really influences the sensitivity? Well, if we look at this paper by Chu, this was a prospective study which was stopped earlier than their planned recruitment, because they found that if you looked at patients with tumors that were less than 4 centimeters in size, and no enlarged lymph nodes on MRI, PET in the pelvis and para-aortic position had a very, very low sensitivity. So there's no evidence that this really performs well in early-stage disease. But in late-stage disease, it's very helpful in identifying lymph nodes. So if we have a case like this, a locally advanced tumor with parametrial extension, we can see this left para-aortic node. And the question is, could this be a nodal metastasis? Because then the radiation field would have to be extended up into the retroperitoneum. And this is a very important area, certainly in the UK and in many gynae centres. So if we look at the FIGO staging of cervix cancer on MRI, in early cases, the patients are suitable for radical surgery. In advanced cases, they'll go for chemoradiotherapy. And we want to know about nodal metastases. In the case of early disease, really, at the moment, the best option is for nodal surgery, nodal dissection, whereas in chemoradiotherapy, in these patients, certainly in the UK, they will now go as standard to FDG PET-CT in order to identify the exact extent of nodal metastases, to plan the radiotherapy field, and indeed, if the patient needs chemotherapy. If we look at the meta-analyses, the PET-CT has a higher diagnostic performance than CT or MRI and is best in cases that are of inoperable disease being planned for curative chemoradiotherapy. Here we have an example of a case, a really extensive advanced disease. We can see this lymph node here over in the pelvis and on the diffusion. We can see the tumor going down the vagina. This patient will not go for radical surgery, but will go for chemoradiotherapy. And in this case, if we look at the PET, we can identify this positive node, but we can also identify nodes higher up in the parametrium. And this will very much change what happens to the patient's care. So this is just a little one for you to look at yourselves. It's just you don't have to put your hand up. I can't even see the hands from here because the lights are so bright. This is a patient with a locally advanced cancer. She's 25 years old, and this was a clinical case that came to us for reporting. But I'd seen the MRI, and I think one of my colleagues reported the PET, and this is a pitfall that I'd like you to have a look at. Over here, we got the locally advanced cancer, and then we had this appearance in the pelvic side walls. And the question is, are these the patient's ovaries, or are they necrotic nodes? Now, in my reporting practice, I would instantly go to the MRI. And I don't know what you all think. It's just, you just in your mind, you have to decide. And in fact, I knew, well, in fact, this is her CT, but I knew that she had these big necrotic lymph nodes from her tumor. But what was causing difficulty on the PET was that because she was so young, she wanted to have egg retrieval for fertility, for use of eggs in the future. And she had these enormous hyperstimulated ovaries in her pelvis, which then confounded the diagnosis in the pelvic lymph nodes. So I think it's very important to correlate the PET with the other imaging that we have available to us to get to the right diagnosis. The other issue is that, of course, necrotic nodes are often not FDG avid because they've become so necrotic that the FDG is not taken up. So it's just one of those pitfalls. Now, PET in radiotherapy planning is very important, certainly in our institution, and will define the gross tumor volume. And if we look at the literature, there has been a change in treatment strategy with either a change in the field definition or the change in dose. And 60% of locally advanced cervix cancer had more than 20% change in the GTV or 27% management change in the way they were going to plan their radiotherapy. And so this has become a very important role of PET in locally advanced cervix cancer. What about in recurrent disease? The problem with cervix cancer is that following primary surgery, the patient, once patients recur, their outlook is poor. But following primary surgery, they can be offered chemoradiotherapy. But we need to define the extent of disease, again, for the radiotherapy field. And if the patient has already had chemoradiotherapy as their first treatment, often they can't have repeat radiotherapy. So the only potential cure is salvage surgery such as exenteration. And in this case, it's very important to note if there's disease beyond the local recurrence. And this is a very strong indication for PET. Is there disease outside the pelvis that can't be resected? Because in that case, there's no point in doing a very big exenterative surgery. And also, we know that the repeat imaging will give us prognostic information. And then, should the patient have disease outside the pelvis, consider an entry into clinical trial. Just to show you a couple of examples, this is a patient who had a recurrence following radical surgery here in the pelvis. And you can see that this was very slightly FDG avid following the end of treatment, but not too bad. And then she had further treatment, and then this became completely FDG non-avid. On MRI, we really couldn't say, was this still disease or not? FDG was very, very satisfactory, and this was biopsied nonetheless and found to be disease-free and just simply fibrosis following treatment. So we can use this for follow-up of patients. Here's a patient that had a stage 3 cervical carcinoma. After treatment, we had this residual area of intermediate T2 signal intensity. It was biopsied and was proven to be a tumor. So the question was, could she have an exenteration? So she then had a recurrence, a PET, and we can see the recurrence here in the pelvis, but she had no other site of FDG uptake, and she was suitable for exenterative surgery. However, if we look at this case, this patient had a post-chemotherapy recurrence in the pelvis, but on her PET we could see that she had FDG-avid lymph nodes in the retroperitoneum and in the mediastinum, and she was not suitable, therefore, for an exenterative procedure. And a PET is very sensitive and specific in the recurrent setting. Here's an example where we can see a patient with advanced disease. We can see a lymph node over here on the MRI. And this is a case where we're going to consider what is her radiotherapy planning. Here we've got a positive paraortic lymph node, and the positive pelvic lymph node, and initially the paraortic lymph nodes were negative. And here, 3 months following radiotherapy, we can see that that node has become completely negative. And at this point, the patient did not have radiotherapy up in the retroperitoneum because the nodes were negative. But unfortunately, on follow-up, we can see this recurrence beyond the radiotherapy field, and that could now be targeted for radiotherapy. PET is very good at predicting prognosis in cervical carcinoma. The pre-treatment SUV max of the primary tumor in a large study was an independent predictor of recurrence and patient outcome. And we also know that the metabolic response rate is very strongly associated with the progression-free survival. And these are in quite large studies now, and it's quite well established. So PET has a strong role in predicting prognosis. So if we look overall at the role of PET in cervix cancer, we can see that it's no good in staging early cervical carcinoma, but in locally advanced cervical carcinoma, it's extremely helpful, and in this case, for treatment planning for radiotherapy, in response assessment, and is very useful in suspected recurrence and prognosis. I'm going to talk briefly about endometrial carcinoma. PET does not have a big role in this area. It's not indicated for primary staging. Surgical staging remains the standard of care. There's a possible use in advanced disease in cases where surgery may be contraindicated in order to plan a radiotherapy field if surgery is contraindicated only. And new traces are being evaluated which may improve outcomes in using PET in endometrial carcinoma. But if we look primary disease, we can see here that for nodal detection, PET has not performed well. So the sensitivities are really quite low, and it really can't be advocated in the primary disease setting. New traces are being developed, and we are currently doing a study in the United Kingdom looking at choline PET, which is essentially incorporated into the cell membrane phospholipids. It's used extensively in prostate carcinoma now. It has different options for choline PET. The one that we're currently using in the UK is the F-ethyl choline. It does have urinary excretion, but we're evaluating its role in both cervical and endometrial carcinoma in the States, in the United Kingdom. So here's an example from our study. It's called the mapping study. It's funded by the Cancer Research UK, and we're comparing size criteria with diffusion, FDG, and this is the FEC PET, but the results are not available yet. We've recruited nearly 30 patients to date, but we'll see if it performs any better. In recurrent disease, of course, we know that MRI is very good at looking at local recurrence, and this typically occurs early on in the first 6 months, and 98% of recurrences occur in the first 3 years. And surveillance of high-risk patients is a useful strategy, but not with PET. When there is a high suspicion of PET, then FDG can be used, again, for treatment planning in salvage disease. So here's an example of a patient who's recurred in her nodes, and again, this can be used for treatment planning in some situations, but in selected cases only. And sometimes we see an equivocal lesion, for example, this lymph node in a patient with previous endometrial carcinoma, and we can see on the PET that this is indeed FDG avid, and a decision will now have to be made in the MDT about how to manage that further. And we know from the literature that, unlike in the primary setting, PET does perform quite well in the recurrent setting with quite good sensitivities for detection of sites of distant disease. And the specificities are very, very high. So if we do see a positive site of uptake, this is highly likely to be a site of disease. But of course, we know that diffusion is perhaps catching up. This is a patient who's got a recurrence in the vaginal cuff with some nodal disease. And if you compare her PET, we can see the PET with the DWI, we can see the same sites of disease on diffusion. And with further technical developments, that may be suitable in the future. So we can see in the endometrial setting, we don't really use this for staging, treatment planning, or response assessment, but we can use it in the setting of recurrence, and there is some prognostic information that I haven't gone into. And I'm just going to finish up now in the last 5 minutes with some information about ovarian cancer. Again, PET really has a big role in cervix, but in ovarian cancer, probably it's more in a research setting. But I will show you some evidence where it may be of interest. So probably in this audience, I don't need to tell you that ultrasound is used for initial detection, not typically for ovarian carcinoma. MRI, as we know from Isabel, is superb for MRI characterization of sonographically indeterminate masses. And typically, if ultrasound demonstrates an obvious ovarian carcinoma, we go to CT for staging. MRI is under evaluation using DWI, and I'm going to talk about some of this data side by side with PET. Because just recently, Mikkelsen et al. In Vincent van der Cave's group in Leuven have just published this wonderful paper where they compared whole-body MRI using diffusion on a 3T scanner with FDG PET in suspected ovarian cancer, and all of these patients then subsequently went to surgery. And this is just an example of one of their pictures from their paper that was just recently published, and we can see the value of the MRI with diffusion demonstrating these small sites of disease which are typically not visible on PET. So small sites are much more difficult on PET to pick up. And what did they find in their results? They found that in peritoneal staging accuracy, the whole body MRI with diffusion was 91% accurate, whereas the PET was only 71% accurate, predominantly because of these small sites of peritoneal disease. But whole body MRI and PET were equivalent for retroperitoneal lymph node staging. And for distant metastases, interestingly, I mean, I really thought that the PET would do better, but they had a strong correlation between the sites of disease in distant metastases on the PET and the DWI. Sometimes we end up using PET in suspected ovarian cancer as a problem solver. And in this case, I don't know if you can see there are two pathologies here, but we can see that there is a mass in the sigmoid colon, and there are bilateral adnexal masses. You can see the mass in the sigmoid colon here. And in the end, we ended up doing a PET CT in this case, and we could see that this had very high uptake. I mean, the problem is that sometimes an ovarian cancer can go through into the sigmoid colon, or sometimes we can have metastases in the ovaries. And in this case, there was some question, and we ended up doing a PET, and we can see the FDG-avid tumor, but the ovarian masses indeed were not FDG-avid. And this patient was found to have a colorectal carcinoma, which perhaps looks obvious after the event, but at the time there was a lot of discussion. Detection of recurrent disease in ovarian carcinoma is a different kettle of fish. We don't use PET routinely in the primary staging, but in recurrent disease, it's a little bit of a hot topic and a controversy, if you like. So PET does perform. We know that there's unexpected tumor beyond the abdomen or surgically inaccessible areas in about 28% of patients, and we know that PET can change management. It has a high diagnostic accuracy, and what is considered the highest clinical utility is in patients who have a rising CA125, but no evidence of disease sites on the CT scan. If we then do a PET, we can very often detect where the disease has recurred. But this is controversial because there's been no evidence that detecting the site of disease in relapse extends the outcome for the patient. Here's an example for a patient with an ovarian cancer recurrence. She had her CT scan, and we can see this small node here in the retroperitoneum, which would not enlarged on size criteria, of course, so we don't know whether this is the site of relapse or not, but here we can identify this as a site of relapse, bearing in mind that PET will not identify small peritoneal deposits, but there may be a consideration for a resection if there's a solitary or maybe one or two sites of disease. There may be a discussion in the MDT about resecting that site. Here's another example. She was a young patient. She'd previously had a serous borderline 6 years ago, and she had a CA125 progression. This patient was young, and of course we wanted to try and offer her treatment. Even again, as I say, there's no good evidence for that. But we can see on her CT scan, this is a non-contrast CT scan, but it's very difficult to see the site of relapse, whereas it's barn door obvious on the PET. So we can see the sites of relapse, but the question is, does that really help the patient? Until they have a more symptomatic relapse, starting treatment early has not been shown to improve their outcome. Now, what about predicting response to chemotherapy? Because this is, again, another big hot topic. Can we use PET after a single cycle of chemotherapy to say, yes, this patient is responding or not to the chemotherapy? And the first thing that we have to do as radiologists is to make sure what the boundaries of our test is. And in our center, we did a retest study in patients with platinum-resistant recurrent ovarian carcinoma at 2 different centers using 2 different PET scanners just to evaluate what was the normal variation. And so the patients who agreed to do this had a baseline. All of these patients had recurrent ovarian carcinoma, I have to say. And this was through the ethics committee, and they agreed for us to do this study in order to evaluate chemotherapy response in the future. The patients had a baseline, and then they had a second baseline at a median of 2 days with a range of 1 to 4 days. And we looked at the concordance correlation coefficient for the SUV mean and SUV max, which were extremely high, and the coefficient of repeatability with SUV mean and SUV max at 16% and 17%. And what this tells us is that within the range of 16 to 17%, that does not indicate a change in SUV uptake. So anything beyond that would indicate a change. And we can use this for response assessment. And here's an example from first we did the test-retest study and then a longitudinal study during chemotherapy. And we can see this patient with recurrent ovarian carcinoma post-cycle 1. We can evaluate the SUV mean and max changes. And in this study, we found both actually in primary disease and in recurrent disease that FDG PET is more accurate than the clinical factors of RECIST and CA125 in predicting responders and non-responders. And if we look at the outcome, this is in primary disease, metabolic responders and non-responders had a very different outcome in their overall survival, with the responders having a median survival of 38 months, whereas the non-responders, 23 months. And we've now repeated this study in patients with recurrent disease as opposed to primary disease, and we've also found that there's a significant difference in responders and non-responders. And this is after a single dose of chemotherapy, so we don't have to wait to find out if the patient is a responder. If the patient is a non-responder, they can be offered an alternative treatment. So if we, just to finish up, look at the ovarian carcinoma, we're waiting to see, Vincent's study is so interesting, but I don't think PET is going to really have a role in staging. I think MRI may take over. Treatment planning, not really. But in certain circumstances, potentially. Response assessment is becoming very interesting. It can be used in recurrent disease in individual patients, and it does have a strong influence on the prognosis of the patient, certainly in the response assessment setting. So thank you very much indeed for your attention.